Welcome to the Deep Microbiology channel, continuing our urinary microscopy series. Today we present an insightful lecture on urinary crystals microscopy. Let's dive in. Crystalluria. Crystals in urine or crystalluria are solid particles formed from minerals and salts in urine, often detected during urinalysis. These minerals and substances include 1. Calcium, found in calcium oxalate or calcium phosphate crystals. 2. Oxalate, a compound in foods like spinach and nuts, which can bind with calcium. 3. Uric acid, a waste product from the breakdown of purines in the body, linked to gout or acidic urine. 4. Magnesium ammonium phosphate, struvite, found in urine with bacterial infections that increase ammonia levels. 5. Cysteine, an amino acid associated with the rare genetic condition cystinuria. These substances generally remain dissolved, but may crystallize under specific conditions like dehydration, pH imbalance, or high concentrations. Now, let's explore the factors influencing the formation of urinary crystals. 1. Dehydration. Low water intake or excessive fluid loss, such as sweating and diarrhea, concentrates urine, making it supersaturated with solutes like calcium, oxalates, uric acid, or cysteine. This creates favorable conditions for crystal formation. 2. High-protein diets. A high-protein diet can contribute to the formation of crystals in urine by lowering urinary pH, making it more acidic. When protein is metabolized, sulfur-containing amino acids, such as methionine and cysteine, are broken down, producing sulfuric acid. Acidic urine reduces the solubility of uric acid, increasing the likelihood of crystal formation. Also, this acidity increased calcium excretion in urine, hypercalciuria. So to buffer the increased acid load, the body mobilizes calcium from bones, releasing it into the bloodstream, which eventually leads to elevated calcium excretion by the kidneys. Additionally, high dietary protein increases renal filtration rates and promotes calcium loss through urine. Also, this acidity leads to reduced urinary citrate levels. So, under these acidic conditions, the kidneys reabsorb more citrate to use as a base to neutralize systemic acidosis, leaving less citrate available in the urine. As we know, citrate acts as an important inhibitor of calcium oxalate and calcium phosphate stone formation by binding free calcium in the urine, preventing its crystallization. 3. Genetic conditions, such as cystinuria and primary hyperoxaluria. Cystinuria is an inheritable, autosomal recessive genetic defect that affects the proximal renal tubular reabsorption of cysteine. In cystinuria, cysteine becomes less soluble in the slightly acidic to neutral range of typical urine pH, around 5.5 to 6.5, promoting crystal formation. Primary hyperoxaluria is an inherited metabolic disorder where the body overproduces oxalate due to enzyme deficiencies. The excess oxalate combines with calcium in the kidneys to form calcium oxalate crystals, leading to crystalluria. Systemic infections, such as urinary tract infections caused by certain bacteria like Proteus mirabilis, produce urease, which hydrolyzes urea to ammonia, raising urine pH and making it more alkaline. This promotes the formation of struvite crystals, magnesium ammonium phosphate. Gout. Gout is caused by the accumulation of uric acid in the blood, hyperuricemia, due to increased production or reduced excretion of uric acid. Excess uric acid in the bloodstream is filtered by the kidneys, leading to supersaturation of urine with uric acid. In acidic urine, uric acid precipitates to form uric acid crystals. Hyperparathyroidism results in excessive secretion of parathyroid hormone, PTH, which increases calcium release from bones and enhances calcium reabsorption in the kidneys. The elevated calcium levels, hypercalciuria, in urine promote the precipitation of calcium salts, such as calcium oxalate or calcium phosphate crystals, especially in alkaline urine. Chronic liver diseases impair amino acid metabolism, leading to the accumulation of abnormal metabolites, such as tyrosine and leucine in the blood. These metabolites are excreted in urine, where they crystallize into tyrosine crystals or leucine crystals. 5. Medications. Certain drugs, including sulfonamides and indinavir, can crystallize in the urinary tract, causing drug-induced crystalluria. This phenomenon is dose-dependent and is significantly influenced by urine pH, solubility of the drug, and concentration. Sulfonamides, for example, can crystallize when their solubility decreases in acidic urine. The metabolites of sulfonamides may also form needle-like crystals, arranged into shocks or sheaves of wheat or shells, which can cause irritation and blockages. Indinavir, an antiretroviral drug, can crystallize in neutral or alkaline urine, forming needle-shaped crystals, often arranged into plate-like, fan-shaped or starburst patterns, may lead to urinary obstruction or pain. 6. Temperature. Crystals are more likely to form at lower temperatures, as solubility decreases with cooling. For example, compounds like uric acid, calcium oxalate, and phosphates, which are normally soluble in body temperature urine, around 37 degrees Celsius, can exceed their solubility limits as the urine temperature decreases. This leads to supersaturation and subsequent crystallization. In stored urine samples, the cooling process mimics this effect, making previously dissolved substances precipitate. This phenomenon is significant in clinical diagnostics, as crystals observed in a cooled urine sample may not accurately reflect the physiological conditions in the body at the time of urine collection. Understanding this effect is crucial for interpreting results and distinguishing between pathological crystalluria, occurring in the body, and artifacts due to sample handling. Now, let's explore the various types of urinary crystals and their medical importance. 1. Uric acid. 2. Amorphous urate. 3. Calcium phosphate. 4. Calcium oxalates. 5. Bilirubin. 6. Tyrosine. 7. Leucine. 8. Cholesterol. 9. Cysteine. 10. Amorphous phosphate. 11. Triple phosphate. 12. Biorates or ammonium urate crystals. 13. Drug crystals. 1. Uric acid crystals. Morphology: yellowish to reddish-brown, varying sizes and highly diverse shapes such as rosettes, rhombic plates, dumbbells, barrels, and diamond, found in acidic urine. Clinically, these are associated with conditions like elevated uric acid levels and gout, nephrolithiasis, kidney stones, cytostatic therapy, and fever. We can remember these shapes by comparing them to natural objects. For example, rosette shape looks like a flower or a rose. Rhombic plates resemble this rhombus plate, and dumbbell shape look like a small set of weights used for exercise. Barrel shape resembles small cylindrical containers, and diamond shapes are just like the gemstone or the diamond-shaped pattern. 2. Amorphous urates are brown, amorphous salts that resemble grains of sand. They can appear isolated or densely concentrated in clusters, and may sometimes simulate casts, as discussed earlier in the cast lecture. These salts are typically found in urine with an acidic pH. When amorphous urates are present in large quantities, the urine sediment often takes on a bright pink color. This color results from pigmented compounds such as uroerythrin, a naturally occurring pigment linked to uric acid metabolism. They differ from amorphous phosphates by pH and solubility characteristics. Amorphous urates have no clinical significance. Three. Calcium phosphate. Morphology: comparatively rare, colorless, shiny, rectangular or wedge-shaped crystals that may be arranged individually or in a fan configuration, in rare cases also arranged in plate form. Found in alkaline urine, clinically associated with bacterial urinary tract infection, and bacteriuria, with urea-splitting bacteria, such as Proteus. 4. Calcium oxalates. Morphology: colorless and translucent in bright field mode, extremely shiny with a high refractive index, are typically found in acidic to slightly alkaline urine. Calcium oxalates. They come in two forms. 1. Monohydrate or woolite. These appear as ovoid where it's similar to some bean seed as you can see here, an hourglass-shaped or dumbbell, also in a picket fence-shaped crystal. 2. Dihydrate, wetolite. These are usually square or envelope-shaped. Calcium oxalate clinical significant. An increased level of calcium oxalates can indicate nephrolithiasis, or ethylene glycol poisoning, which is main component of antifreeze. 5. Bilirubin crystals are seen in the urine when the serum bilirubin level is increased. The macroscopic appearance of urine with bilirubin crystals is orange in color. The crystals themselves appear as gold-orange needle-like forms that are sometimes clumped together. Bilirubin crystals are associated with liver disease or obstruction. 6. Tyrosine crystal. Morphology: extremely rare. Found in acidic urine, shiny colorless to yellow-brown, extremely fine needles, single or lying together, needle bundles, some of which are also found intracellularly in leukocytes. Leukocytes pierced by needles are particularly easy to identify in bright field mode. Note: tyrosine can be confused with nonspecific crystalline needles. Also, morphologically, bilirubin crystals can be differentiated from tyrosine crystals by their appearance, as bilirubin crystals are less needle-like compared to the needle-like structure of tyrosine crystals. Tyrosine crystals associated with severe liver damage. 7. Leucine crystals. Morphology: brownish-yellow in color, spherical with radial striation, found in acidic urine pH. Note: leucine is extremely rare and should not be confused with ammonium urate. Leucine crystals clinically associated with severe liver damage. 8. Cholesterol crystals. Morphology: cholesterol crystals appear as colorless, flat, rectangular plates with notched corners and weak birefringence under polarized light. pH and specific gravity. They are typically seen in acidic urine with normal specific gravity. Associated findings: their presence is rare and must be supported by accompanying signs, such as proteinuria and lipiduria. Free-floating fat droplets, fatty casts, oval fat bodies, and large amounts of protein often accompany these crystals. Clinical associations: they are indicative of nephrotic syndrome and can also be seen in conditions leading to chyluria. 9. Cystine crystals. Morphology: colorless hexagonal shape, sometimes with irregular sides, thin discs, single and sometimes superimposed. In older urine samples, cystine crystals may take on a brownish color, and the typical hexagonal contour is only partially or no longer visible. For that, it is better to use a fresh urine samples. Cystine crystals are found in acidic urine. Note: thin, hexagonal uric acid crystals can resemble cystine, as you can see here in picture. Therefore, a confirmatory test such as nitroprusside test should be performed before cystine crystals are reported. Nitroprusside test is a biochemical test used for the detection of the free sulfhydryl groups in amino acids or the cysteine amino acid in a protein. Cysteine and methionine are two amino acids with sulfhydryl groups, but the sulfhydryl groups in the methionine molecule are involved in the thioester linkage, which is difficult to break and thus cannot be detected by this test. For that, this test is a specific test for cysteine, as it is the only amino acid with a free sulfhydryl groups in the structure. Procedure of nitroprusside test: add 2 milliliters of sample to the test tube. and add 0.5 milliliters of the freshly prepared sodium nitroprusside, and mix thoroughly. Then add 0.5 milliliters of the concentrated sodium hydroxide, where it is provide alkaline medium, which is critical for activating the nitroprusside reagent, allowing it to react and form the colored complex. The positive test tube is observed for the color change, or the formation of a red colored complex. If a positive result is not observed immediately, the test tube can be heated in a water bath for 2 minutes. Clinically, cystine crystals it is associated with cystinuria, hereditary metabolic disease, involving a tubular reabsorption disorder for cysteine, arginine, ornithine and lysine. Only the amino acid cysteine crystallizes at an acidic pH value. Also associate with cystine stones. 10. Amorphous phosphate. Morphology: white to gray, small crystalline grains of sand, lying individually and in clusters. Their color can only be determined microscopically in bright field mode. Macroscopically, sediment is whitish-gray in color, found in alkaline or natural pH. Amorphous phosphates are differentiated from amorphous urates on the basis of urine pH. Soluble in acid, in large quantities of amorphous phosphates cause a urine specimen to appear cloudy. The precipitate is white or gray, in contrast to the pink-orange color of amorphous urates. Amorphous phosphates have no clinical significance. 11. Triple phosphate, ammonium magnesium phosphate, also known as struvite crystals. Morphology: colorless and appear in several different forms. The most common and characteristic forms are 3 to 6-sided prisms with oblique terminal surfaces, the latter described as coffin lids. Their size can vary greatly. With prolonged storage, these crystals can dissolve, taking on a feathery form that resembles a fern leaf. Present in alkaline to natural urine, triple phosphate crystals have little clinical significance, but have been associated with urinary tract infections characterized by an alkaline pH, and have been implicated in the formation of renal calculi. 12. Biurates crystals. Ammonium biurate crystals appear as yellow-brown spheres with striations on the surface. Irregular projections or spicules can also be present, giving these crystals a thorny apple appearance. They can form in alkaline or neutral urine. These crystals occur most frequently in urine specimens that have undergone prolonged storage. They are clinically significant because in vivo precipitation can cause renal tubular damage. Note: ammonium biurate crystals can resemble some forms of sulfonamide crystals. Differentiate between them based on their urine pH, a sulfonamide confirmatory test, and the solubility characteristics of the crystals. 13. Drug crystals. Most drugs and their metabolites are eliminated from the body by the kidneys. As urine forms within the nephrons, high concentrations of these agents can cause their precipitation out of solution. These crystals are termed iatrogenic, which means that they are induced in the patient as the result of a treatment. Proper identification and reporting of drug crystals are important, because if the crystals are forming in vivo, for example in the renal tubules, they can cause kidney damage. Most common medication that cause crystals in urine are 1. Ampicillin. Ampicillin crystals appear as long colorless, thin prisms or needles. Present in acidic urine, ampicillin crystals indicate large doses of ampicillin and are rarely observed with adequate hydration. 2. Indinavir. Indinavir sulfate crystals are slender feather-like crystals that aggregate into wing-like bundles, which can also associate into a rosette-like or cross form. Indinavir and other antiviral drugs can be present in acid urine, but are more often observed in neutral and alkaline urines. 3. Sulfonamides. Sulfonamides appear in various forms that differ depending on the particular form of the drug prescribed. Sulfadiazine drug crystals usually appear yellow to brown, and as bundles of needles that resemble sheaves of wheat. But, currently, sulfonamides have been modified, and their solubility is no longer a problem. As a result, sulfonamide crystals are not found as often in urine sediment, and renal damage caused by them is uncommon. Thanks for watching. If you enjoyed the content, don't forget to subscribe to Deep Microbiology channel and turn on notifications to stay updated.